Thanks for the organizer committee to give me a chance to visit Taipei and to give a talk about the APL. APL, right now everybody are very familiar with this diseases with introduction of ultra and arsenic, making this disease into a very favorable subtype for AML. Recently, a trend of upfront treatment with ultra and arsenic combination much improved overall survival and event-free survival. So there was a trend to try to using minimal chemotherapy or even no chemotherapy for newly diagnosed patients. So the rationale of this chemo-free regimen is a very appealing concept that we can using two non-chemo cytotoxic target drug to cure a leukemia and to avoid totally the toxicity of chemotherapy. And there was a lot of laboratory study to show the synergy of ultra and arsenic. And here is an example that Hugh Day and Scott Cogan has using a beautiful mice model to predict that since only retinoic acid and arsenic can degrade very rapidly PMI of oncoprotein, which led a rapid eradicating of leukemia stem cells. Then in mice model, this combination without chemotherapy can cure APL. So what is the clinical data? First, last year there was a very exciting publication from Jemima Group, their clinical trial using ultra and arsenic without chemo in low and intermediate group of APL. In their study, this is a Ranma Study, they using ultra and arsenic alone as induction and post-remission therapy compared to their standard AIDA, that ultra and adorubisin induction, consolidation, and maintenance therapy. So you can see the complete remission rate is the same, and even the 2-year event-free survival seems to be better in the chemo-free ultra and arsenic combination. This combination has led to less deaths in CR and similar relapse. So the overall survival is also seems to be better. So their conclusion is for newly diagnosed non-high-risk APL, the chemo-free ultra and arsenic therapy is at least not inferior to chemotherapy containing AIDA therapy in terms of 2-year event-free survival. So this is very exciting results. Thus, last year, the NCCN guideline has adopted this new frontline therapy as an option for low and intermediate APL. Unfortunately, we don't have much data on the chemo-free regimen in high-risk APL, and what we have is only those ultra and arsenic with minimal chemotherapy in high-risk APL. So I tried to summarize 4 different publications and group study. They are using different strategy, combine ultra and arsenic, either in induction, maintenance, consolidation, and different cycle of ultra and arsenic combination. So here is the standard approach. In our institute, we're using ultra arsenic as induction, adding some chemo to control hyperleukocytosis, consolidation with 3 chemo regimen, and then afterwards giving ultra arsenic and low dose chemo maintenance. This data several years ago already published. At that time, about around 85 patients. The overall survival and event-free survival is around 90% for all patients. When we updated follow-up to more than 180 patients last year, we divide patients into low, intermediate, and high risk. We will see low risk and intermediate dose have a similar overall survival and relapse-free survival. But for high-risk patients, the relapse-free survival is 10% less than low and intermediate group. So from this curve, you can see clearly a gap, and particularly for high-risk group, we have identified several late relapse. The second study is published by MD Anderson Group. They are using ultra arsenic without chemo, but with Mylotarg, still a cytotoxic drug. They are using this combination for high-risk patients and in low-risk patients without Mylotarg. And still, the same curve This is for low risk patient. This is for high risk patient. You can see there was still a lot of much inferior outcome in high risk patient. The third study is the North American intergroup study. They are using Ultra and daunorubicin as a standard induction and adding 2 cycles of arsenic alone as a consolidation, followed by 2 cycles of Ultra and daunorubicin consolidation. And you will see adding of arsenic much improve the overall survival and relapse-free survival. But unfortunately, without Ultra or even adding Ultra, there was still a huge gap between patients with low-risk disease and high-risk diseases. More interesting is the Australia APM4 study. They are using 3 cycles of Ultra and arsenic in induction and consolidation. And the whole therapy, they're only adding 1 cycle of adenosine in induction. So this is a combination of Ultra and arsenic with very minimal chemotherapy. They have a very nice data, 2 years relapse-free survival around over 95, failure-free survival around 80, overall survival more than 80. But when you divide the patient again into low, intermediate, and high risk, you can still see the high risk have a worse outcome. The failure-free survival at 2 years is around 75. So I tried to summarize all this data. It seems that for low and intermediate risk, they have a similar outcome. But for high-risk patients, even with chemotherapy, you get worse results. It's about 20, more than 10 or 20% less survival. So for high-risk patients with the current data, arsenic Ultra combination with or even minimal chemotherapy, the initial high white blood count still remain as a high-risk factor. This high-risk factor is associated with higher early death rate and relapse rate. The long-term outcome is not still satisfactory because we may lose about 25% of these patients due to early death or relapse. So chemotherapy, it seems to be still necessary in this high-risk group. The third group patient we should focus is the relapsed patient. Even though with this improved combination of Ultra arsenic or chemotherapy, there was still some patients with relapse. So we look at this publication. This is a Fatima study focused on the arsenic Ultra treatment in relapsed APL. They divided patient into, this is a Rationale study, they into 2 groups, the chemo group giving Ultra and mitoxantrone and chemo consolidation. For arsenic group, they're giving arsenic with Ultra, sometimes with also some chemo, but for consolidation, only Ultra and arsenic without chemotherapy. You will see the CR rate is the same, molecular CR rate is the same, the overall survival, disease-free survival, or leukemia-free survival, it seems to be similar. But when we divided those patients into not receiving autologous transplantation and autologous transplant, there was seems to have a trend of big difference because in patients that not receive autologous transplantation, the long-term overall survival seems to be better in chemo group than the arsenic group without chemotherapy. But when you're adding high-dose chemotherapy followed by autologous transplantation, the chemo group seems to be do the same. But in arsenic group, it's much improved. So this data may suggest that for relapsed patients, their arsenic can give benefit, but this benefit is based on the presence of chemotherapy or autologous transplantation. Because more and more patients now receiving Ultra and arsenic as a frontline therapy, and there was still small percentage of patients with relapse, so the resistance to Ultra and arsenic will become more and more important clinical problems. So there was a very beautiful review recently by Dr. Naui, published last year. He beautifully summarized the mechanism of resistance to Ultra and arsenic. Here is the PMI protein. This is a multi-IR alpha which were combined with Ultra which will induce cell differentiation. And here is the B2 domain of PML, which is the moiety arsenic will target this PML part and leading to simulation of the protein, then leading to the degradation of this PML leukemogenetic protein. Thus, there was a lot of clinical report about ultra mutation, IR alpha mutation, and there was a more recently report of 2 cases of this B2 domain PML mutation, which led to the resistance to arsenic. So for relapsed patient, we can see that in relapsed patient, the combination of ultra arsenic can achieve a remission, but the long-term survival is still not satisfactory. Unless chemotherapy is added to this relapse and refractory patient, or sometimes autologous transplantation if a molecular remission can be achieved, or even allogeneic transplantation is added, then this relapsed patient outcome is much improved. And the resistance to ultra and arsenic in the era of ultra-arsenic combo frontline therapy will become a problem, particularly the PML alpha mutation. So the conclusion is frontline therapy with ultra and arsenic without chemotherapy is not curative for all newly diagnosed APL. This combination, chemo-free combination, is sufficient for low-risk and intermediate-risk APL, but not for high-risk patient. For high-risk patient, chemotherapy should be added, and in case of relapse on the refractory patient, chemotherapy also should be added. Thank you very much.
With that, can we have our speakers come up?